The information in this video will provide you with a better understanding of total joint replacement surgery. Your options and their benefits to you will be explained, as will the important guidelines for postoperative care and compliance. The long-term goal of total joint replacement surgery is to provide pain relief, restore normal activities of daily living, and enhance your overall quality of life. Hip and knee joints worn out or damaged by arthritis is an age-old problem. There was no long-term solution for this problem until the early 1960s, when the first successful total hip replacement surgery was performed in England. By the mid-60s, total joint replacement had been imported to this country, and since that time has gradually been improved to the point where it is now quite successful. The results of this surgery have been spectacular and the complications few, as the benefits are regularly extended to both the young and the young at heart. Unfortunately, there are common misconceptions about what total joint replacement is. Although it sounds like it may involve the amputation of a portion of your body, it is simply the resurfacing of the relatively small portion of your bones affected by arthritis. For most patients, this restoration of joint function returns them to an active lifestyle they haven't experienced in years. If you still have unanswered questions after viewing this video, please sit down with your physician, who will be happy to go into further detail regarding total joint replacement surgery. Also, you can further research the procedure and the implant technology your surgeon uses at www.smith-nephew.com. The hip joint functions as one of the most important joints in the human body. Designed for both mobility and stability, the hip allows the entire lower extremity to move in 3 planes of motion, while providing an important shock absorption function to the torso and lower body. The hip is a ball and socket joint made of the femoral head and the acetabulum, which unite the femur or thigh bone with the pelvis. As a result of this configuration, the leg can move forward and backward, side to side, and rotates left and right. Arthritis afflicts 1 in 6 Americans and is the leading cause of disability. The most common form of arthritis is osteoarthritis. It is usually referred to as wear and tear or degenerative arthritis, and occurs most commonly in patients over age 50, but can occur at any age, especially if the joint has been previously damaged by injury. It is normally confined to the large weight-bearing joints such as the hips and knees, but may affect the spine and upper extremity joints as well. The most common symptom is pain in the hip or knee during weight-bearing activities, and in many people the pain is so severe that sleep is regularly interrupted. People with hip or knee pain usually compensate by limping or simply reducing force on the arthritic joint, thus weakening surrounding muscles and making joint stability a further complication. As a result of cartilage degeneration due to osteoarthritis, joints lose both flexibility and strength, and often bone spurs develop on the joint's bearing surfaces. If the condition is allowed to worsen, you may experience pain at all times, even during non-weight-bearing activities. This has obvious negative effects on your lifestyle, perhaps needlessly so. Total joint replacement is now a very viable and successful option for alleviating the pain that accompanies degenerative hips and knees, but it is not the only option. Before considering total joint replacement, you may want to discuss these non-surgical therapies with your doctor. An appropriate weight reduction program may be beneficial for decreasing force across the joints. However, this can be difficult for people with arthritis since the pain precludes them from increasing their activity and burning calories. Your doctor can prescribe specifically designed exercises to improve strength and flexibility without increasing your pain. Various medications such as non-steroidal anti-inflammatory drugs and nutritional supplements may be used to decrease swelling in the joint and provide temporary pain relief. Assistive devices such as canes and crutches may reduce the force transmitted to the joints during weight-bearing activities and thereby may help decrease your pain. These are just a few of the options to consider before committing to total joint replacement surgery. Although many of these solutions may help to temporarily alleviate the pain, they may not give you long-term relief and the opportunity to return to daily activities. If non-surgical treatment is unsuccessful, you and your surgeon may want to begin the discussion about total joint replacement. In total hip replacement, the prosthesis or implant is made of 4 components. The femoral stem is made out of metal, such as titanium, and is implanted down the shaft of the thigh bone or femur. The ball or femoral head is attached to the stem and is designed to replace the arthritic femoral head. The third part, or acetabular component, is a metal shell with a plastic inner socket liner. Each of these components is the result of years of engineering, research, and testing, not only of the mechanical designs, but also of the materials used to make them. Intense work over the last several decades at such companies as Smith & Nephew has produced implants that may last longer and have more successful outcomes than were previously achievable. Scientists work diligently to measure and reduce the friction and wear between the implant surfaces while still retaining the strength and versatility necessary to return the patient to an active lifestyle. Strict manufacturing processes also ensure consistent implant quality by adhering to design specifications practically down to the microscopic level. One of the keys to a successful implant is its ability to withstand the rigors of daily activity, and central to that is the quality of the artificial surfaces that slide against each other or articulate in the new joint. In hip implants, a number of bearing surface options have been used over the last few decades. By far, the most common substance used for the ball is cobalt chrome, a metal alloy typified by its toughness and biocompatibility. However, even this high-quality industry standard has its shortcomings. Over time, the metal surface can become roughened by bone and bone cement particles trapped between the ball and socket during surgery. As you might imagine, this roughened surface, when rubbing against the plastic socket up to 2 million times per year, can more quickly wear out your implant. When that happens, you will have to undergo surgery to replace the plastic acetabular liner as well as the metal ball. In more extreme cases, a patient may develop osteolysis, which is the softening and degradation of bone caused by the body's reaction to the worn plastic particles released around the joint. For this reason, implants have been shown to last between 10 and 15 years in the human body. To combat this plastic wear in an attempt to extend implant life, device manufacturers have tried substances other than cobalt chrome articulating on plastic. For instance, in recent years, some surgeons have begun using a ceramic ball in a ceramic socket. Ceramic components have extremely hard abrasion-resistant surfaces. In fact, a ceramic surface can be up to nearly 5,000 times more resistant to abrasion than cobalt chrome, which can dramatically reduce the joint's wear, thus potentially extending its lifespan. Surgeons have also begun using hip implants that use a cobalt chrome ball in a cobalt chrome socket. Again, by using a hard-on-hard surface, they are attempting to extend the life of the implant by eliminating the plastic liner. The most exciting material to enter orthopedics in recent years is oxinium oxidized zirconium. This remarkable new material combines the strengths of ceramic and metal, such as wear reduction and strength, but does not have the weaknesses such as limited implant options and the possibility of fracture. Zirconium is a biocompatible metal, similar to titanium. When the zirconium alloy undergoes a unique heating process, the surface of the metal transforms into a ceramic. Even though the new ceramicized surface is as abrasion-resistant as actual ceramic implants, it retains the toughness and flexibility of the underlying metal. Because it can achieve this remarkable reduction in implant wear without sacrificing strength as actual ceramic components do, Oxenium brand oxidized zirconium implants have the potential to last significantly longer, thus possibly reducing the need for future corrective surgeries. When articulating on what is called a cross-link polyethylene cup, Oxenium hip implants reduce wear by 98% compared to cobalt chrome moving on a standard plastic cup. Additionally, since oxidized zirconium implants articulate on these high-density plastic cups, surgeons have all of the same implant options as if they were using traditional implants. Before you are taken to the operating room, your anesthesiologist will talk with you about the medications used during the procedure, and he will administer the medications once you are in the operating room. Next, the surgeon will make an incision in your leg to access the hip joint. Your surgeon will select the appropriate incision length and approach that is best for your case. After the incision is made and exposure is adequate, the ligaments and muscles are separated to allow access to the bones of the hip joint. The femoral head is then dislocated from the hip joint and removed at the level of the femoral neck. After the femoral head is removed, the cartilage of the acetabulum is removed using a special reamer that forms a hemispherical shape. The remaining void will allow for a proper fit of the metal shell. A provisional or trial component is placed in the reamed area to determine the proper size and fit. Once your surgeon is satisfied with the size and positioning of the trials, he will implant the metal shell. The next step involves preparing the femoral canal to accept the femoral stem implant. Special instruments are used to hollow out the femur to match the shape of the metal stem of the femoral component. Trial components of the femoral stem, femoral head, and acetabular shell are temporarily implanted to ensure the proper size and fit of the final implants. At this stage, the surgeon will move your hip in all directions to make sure the trial components are implanted appropriately to achieve adequate range of motion. Once he is satisfied with the placement of the implant trials, he will insert the final components. For some patients, a special type of acrylic cement, which is well tolerated by the body, is used to fix the components to the underlying bone. For other patients, the implants are fixed to the bones without cement. In these cases, the implants are coated with a special porous surface that allows the living bone tissue to adhere to the implant. Finally, the incision is closed, an external dressing is applied to the incision, and you will be taken to the recovery room. In the recovery room, the staff will monitor your vital signs until you are transferred to your hospital room. Total joint replacements are very complex procedures. However, the outcomes following surgery are most often very successful. One of the critical success factors for positive outcomes is following the physical rehabilitation process. In order to achieve the goals for a successful total joint replacement, you must actively participate in the rehab process and work diligently on your own. You must cooperate and work with your physical therapist to achieve optimal results. Depending on the procedure performed, rehab techniques and times will vary. Many times, rehabilitation with the therapist begin as soon as 1 to 2 days following total joint replacement surgery. The goals of the rehabilitation process are simple. Return the patient to normal activities as soon as possible, and teach the patient proper ways to perform weight-bearing tasks. The rehabilitation team will work together to provide care and encouragement needed during the first few days after surgery. You may be given a device called an incentive spirometer that you inhale and exhale into. It measures your lung capacity and assists you in taking deep breaths. These exercises reduce the collection of fluid in the lungs after surgery, preventing the risk of pneumonia. The physical therapist will begin as early as 1 to 2 days after surgery. They will teach you some simple exercises to be done in bed that will strengthen the muscles in the hip and lower extremity. These exercises may include gluteal sets, tighten and relax the buttock muscles; quadricep sets, tighten and relax the thigh muscles; ankle pumps, flex and extend the ankles. Your physical therapist will also teach you proper techniques to perform such simple tasks as moving up and down in bed, moving from lying to sitting, moving from sitting to standing, moving from standing to sitting, moving from sitting to lying. Although these are simple activities, you must learn to do them safely so that the hip does not dislocate or suffer other injury. Another important goal for early physical therapy is for you to learn to walk safely with an appropriate assistive device, usually a walker or crutches. Your surgeon will determine how much weight you can bear on your new hip, and your therapist will teach you the proper techniques for walking on level surfaces and stairs with the assistive device. Improper use of the assistive device raises the chance for accident or injury. The occupational therapist will also visit with you to teach you how to perform activities of daily living safely. They will provide you with a list of hip precautions which are designed to protect your new hip during the first 8 to 12 weeks following surgery. Do not bend forward to reach your feet. You must maintain a 90-degree angle between your torso and legs. Do not lift your knee higher than your hip on the operated side. Do not cross your legs. Do not allow your legs to internally rotate, feet turned in. Do not twist while lying or standing. Sleep on your back with a pillow between your knees to prevent crossing. Strictly observe your weight-bearing precautions during standing or walking. As you consider total joint replacement surgery, remember that more than 250,000 people undergo it in the United States each year. It has become one of the most successful surgeries performed, as it can return patients to a level of activity they may not have experienced in years. If you have additional questions about this procedure, talk with your orthopedist. If you would like further information about the joint replacement implant technology your surgeon uses, visit www.smith-nephew.com.